Welcome. Today we're talking about congenital adrenal hyperplasia. In congenital adrenal hyperplasia, this is a disorder of primary adrenal insufficiency, and this primary adrenal insufficiency arises because of enzyme deficiencies. So the commonest cause is 21-hydroxylase deficiency, and this occurs in more than 90% of the cases. So when there is this deficiency, it means that the adrenal gland cannot function properly and it's failing to produce cortisol and aldosterone. So what happens is that cortisol should be giving negative feedback to the pituitary gland and the hypothalamus, but in this case, because it's deficient, there will be no negative feedback. So if you look at this, we have the hypothalamus, the pituitary, and the adrenal gland, and this is the hypothalamic pituitary adrenal axis, and cortisol is the hormone that gives negative feedback to the pituitary gland. So there will be negative feedback to the pituitary gland as well as to the hypothalamus from cortisol. And if cortisol is not there, it means there is no inhibition of production of corticotropin releasing hormone as well as ACTH. So in congenital adrenal hyperplasia, there will be increased ACTH production, and increased ACTH production will lead to hyperplasia of the adrenal gland. The other thing is that with reduced inhibition, the precursor of ACTH, which is the pro-opimelanocortin, will also be increased. And this pro-opimelanocortin is also the precursor to MSH, which is the hormone that causes pigmentation of the skin. So that means in congenital adrenal hyperplasia, the patient will also have hyperpigmentation. So the skin will be hyperpigmented because there will be increased pro-opimelanocortin here. So pro-opimelanocortin will cause hyperpigmentation. So there will be hyperpigmentation of the skin. Okay, the skin will be hyperpigmented. Then this condition is inherited. It's an autosomal recessive condition. So it means that it's on the chromosome 6, and so it means it has to be in both parents. Okay, both the mother and the father must be carriers of the genetic mutation which occurs in congenital adrenal hyperplasia. This condition, if it occurs in girls, okay, it causes virilization, and it can present an ambiguous genitalia which can be seen at birth. So there are disorders of sexual differentiation, and this is a 46XX disorder of sexual differentiation, which means that it is a disorder of sexual differentiation if it is occurring in girls. If it occurs in boys, it's difficult to diagnose because it only presents with hyperpigmentation of the skin, and the genitalia may be enlarged for the age. It's 21-hydroxylase deficiency. The commonest type has got two types. There's the classical and the non-classical type. The classical type usually presents within the first few weeks of life, and the non-classical type presents after 2 years of age. The classical type can be salt wasting, which means that there will be decreased production of aldosterone, or it can be just simple virilization where the sodium is not affected. So on this diagram, the production of aldosterone and cortisol, we start with cholesterol, then it's worked upon, and what I'm interested in this is this step where there is 21-hydroxylase, which works on 17-hydroxyprogesterone on the production of cortisol, and the other here there will be pregnenolone, and it's being converted to aldosterone. So in 21-hydroxylase deficiency, there can be deficiency of both aldosterone and cortisol, and this leads to the build-up of precursors of the or the substrate of 21-hydroxylase builds up, and if it builds up, it then shunted towards the right side, where it is now being used to produce testosterone, and it can be used to produce androsterone, as well as estradiol. These are the androgens which make virilization. So if it's in a female, this will cause virilization, and if it's in a male, it just cause more pronounced effects of androgens. So this is the reason why in female they are virilized. But the fact that if aldosterone is low, then it's salt wasting. Okay. Then if cortisol is low, then the other effects of cortisol deficiencies, we are going to discuss about those as what can occur in adrenal crisis. So in adrenal crisis, this is when maybe if the patient is not on any treatment, then, or if the patient is on treatment, if they just get any simple infection, a simple upper respiratory tract infection, and their doses are not adjusted, they can present with adrenal crisis, and this is when the cortisol response is insufficient to maintain the body's glucose as well as blood pressure. We know that aldosterone is the hormone that's involved. It's a mineralocorticoid which is involved in sodium retention and loss of potassium. So these patients can present with shock because they have low sodium. They can present with hypoglycemia because the cortisol is failing to stimulate the production of glucose, and they can have low sodium and increased potassium. Okay, so this is a typical presentation in adrenal shock, and this is an emergency. Adrenal crisis is an emergency, and it has to be treated as soon as possible with boluses of normal saline. We have to give dextrose containing fluids as well, just after the normal saline, to make sure the glucose goes up, and we have to correct the hyponatremia and address the hyperkalemia. So this is a medical emergency, and the patient has to be admitted to ICU because of adrenal crisis. So with congenital adrenal hyperplasia, if we're talking from birth and the patient is suspected of congenital adrenal hyperplasia, this is because if it's a female patient, they will be having an ambiguous genitalia, so they will have clitoromegaly, they can have a common urogenital sinus and other features. And with congenital adrenal hyperplasia, the first investigation that you may start to do is to do 17-hydroxyprogesterone. So this is the precursor of, or the substrate that 21-hydroxylase works on. So if this is high, it can confirm the 21-hydroxylase deficiency. Then you also do a cardiotype. You want to check if this patient is 46XX or 46XY, because sometimes a patient can have a male genitalia when they're actually having a 46XX cardiotype, and the actually external or the phenotypic manifestations may be just because of virilization. So you want a cardiotype, you want a laparoscopy or a laparotomy to check for the internal organs. If the patient has got female internal organs, do they have an ovaries, do they have uterus, or do they have actually male internal organs? Then a scan of the abdomen is also needed. So if you do these investigations on a patient, then you can tell whether the patient is more likely to be female or a male. And also the decision to decide whether the patient should be a female or a male should be made when the patient is above 10 years. Then the patient will be consulted to decide on whether they want the gender assigning role, whether they want to be assigned a female gender or a male gender. But with these investigations, you can tell the genotypic sex, and you can also tell the phenotypic sex, but the patient will also be consulted to decide on the gender role that they want to be assigned to them. Okay, so